So if you've never done this before, what we do is we have a live Q&A session most Thursdays in life. And what we try and do is absolutely not give you medical advice in any way, shape, or form. What we try and do is give you general medical information, which we hope will empower and help you in your next clinical consultation, but still certainly not take the place of. Anything I've missed in the caveat section, Dave?
No, and I think the reason for that is that there is always lots of additional information. So when we see people in the clinic, we have lots of additional information about the story to date and about the various different tests. And we always go through all of that before we see people in the clinic, because the stories are always a little bit more complicated than they sometimes come across. And we don't have that information, and it's important to have that information. So, the caveat here is always that at face value, the following is what I would think, but it also, always can be a little bit more complicated than that. Indeed. What we try and do is to point you in the direction of the right questions for you to ask, to make sure that you do get the answers that you want.
Yep, perfect. That's helpful. Okay, so here we have Professor Dave Jones. Sometimes I call him Dr. Jones because of the Indiana Jones films.
Yes, thank you.
And the fact that A, he's ruggedly good looking, but B, he also has that kind of maverick element to his persona, and certainly has a history of being the difference and making the difference. So sometimes you'll catch me doing that, but he is here in all his glory. Right, Dave,
all I say about Dr. Jones in the Indiana Jones film is they use very expensive computer technology to make him look younger, and frankly, I need a bit of that. If anybody out there can do video magic and make me look like I'm 30 again, please do.
So, being a charity, we do have a limited budget on that, and unfortunately, you can see that. Right. Let's get started. Right.
Let's get started.
Dear Professor Jones, I was diagnosed accidentally through routine blood tests less than a year ago. After I started URSO, my alk phos went down. FibroScan showed no cirrhosis or steatosis. Also diagnosed with alpha-1.
Yeah.
Does the lack of the alpha-1 antitrypsin, I'm going to say protein, have an influence on PBC?
Okay. So, and then there's the second bit about gallbladder polyps that we'll also pick up. Okay.
Okay.
I was particularly keen to answer this question, and welcome to Slovenia. Welcome to Slovenia. So, for those of you who aren't familiar, I'm just going to talk. We've never talked about this in any of the sessions that I've done, which is one of the reasons why I wanted to cover it. So alpha-1 antitrypsin is a protein that is normally produced by your liver, okay? And what it does is break down inflammatory proteins. So if you have an infection, the body produces a lot of inflammation and it needs to regulate that. And the way it regulates that is through producing this thing called alpha-1 antitrypsin. So it basically damps down inflammation in the body. If you don't produce that protein for whatever reason, you are not as good at damping down inflammation. And this protein can also have other effects if it isn't regulated, one of which is to damage the lungs. Now, historically, people would talk about alpha-1 antitrypsin deficiency. So this is a genetic variation. So it's something that people are born with. And if people have two abnormal versions of the gene, then they tend to get lung disease relatively early in life. And that's what people tend to know about. When I was a medical student back in the 19th century, I said that before Robert can get in there, we used to think of this as a lung disease. It then became very clear that children with two versions of the wrong gene developed liver disease quite early in life, liver disease, okay? And that created an awful lot of interest. And it turned out it was because the protein that wasn't being produced normally the reason it wasn't being produced normally by the liver is it couldn't get out of the liver cells. And so it was building up in the liver cells, okay? And building up and would damage the liver cells. And this would give childhood liver disease. Most disease of the liver in children is genetic. And this was an example of it. So it was a very, very rare genetic disease of liver in children, okay? And the last bit of that story was the recognition that a milder version of what children got could also occur in adults. And when you have the SZ phenotype, is having one abnormality of this gene and one that's not abnormal. Okay, so it's a mild version of alpha-1 antitrypsin deficiency. Now, most people with that mild version don't get any problems at all. They don't get lung disease and they don't get liver disease. The caveat to that is that if you have liver disease for another reason, then the alpha-1 antitrypsin deficiency can make it a little bit worse because of this buildup. So in adults, it's not something that causes liver disease, but it's something that can make liver disease worse in people than it would otherwise have been. And so I have a thing about this, teaching the fellows and the young doctors, that if ever somebody's liver disease doesn't quite make sense, look for alpha-1 antitrypsin, because you could have two effects that are there. Now, the good news is that the information you've given us is really good. So a FibroScan of 4.7 is normal. That's really good. And the alkaline phosphatase wasn't that elevated, and it's come down to essentially normal with the ERSO. So normal biochemistry, and there's no significant scarring in the liver. That's all very good. So what, if anything, does the alpha-1 antitrypsin mean? It means that you should take double care to make sure your liver function tests are normal. Because if you think about it, if your liver is abnormal, it will be worse than it first appears. So the meaning of the alpha-1 antitrypsin is that you're absolutely fine now. Those numbers are brilliant. We love to see alkaline phosphatase values, but we also love to see FibroScan at the same time. Gives us a complete picture. So those numbers are great, but you don't want to have any activity of your PBC at all, because it could end up being a little bit worse. So lower threshold for second line therapy if you need it. So it needs more care and attention. And the other side of it, the other half of FibroScan that people talk about increasingly, is you can look for fat in the liver as part of a workup for fatty liver disease. That's not a feature of PBC, and those tests show you haven't got fatty liver disease. So actually, those are really good tests. The alpha-1 antitrypsin is an oddity, but it is something to think about in people whose liver disease is worse than you would imagine it would do. So somebody who's maybe, never really had really bad liver biochemistry with PBC, for example, and yet they've got cirrhosis. That's the sort of situation you would look for it. And so a number of the people who come to transplant now do so with that combination. So there you go. We've never talked about that before.
We have not. It's a great question. So it's good to know. So with my non-day job, I'm working within alpha-1, so it's really good to know. Yeah. Right. Yeah. Thank you.
So, and just don't go on the internet and read about alpha-1 in children. It's a different disease. It's a completely different beast. Yeah. This is the mild variant, which really doesn't have problems.
Okay, perfect. And so we've got a question now in and around polyps and gallbladders.
Yeah.
Can you talk to us just in general about the gallbladder in relation to PBC? Because we've had many people with gallbladders removed.
Yeah.
And they don't know if it's because of the PBC, if it's proven to be unnecessary and actually it was PBC all the time, or, and looking back, you'll never know. But what can we tell people about the gallbladder, about its relationship with PBC? What do they need to know?
So your gallbladder, it is there to pool bile. Okay, so bile you need to absorb fat from your diet. So fat is not water soluble normally, and so therefore it would just be globules in the bowel if it wasn't solubilized. And so bile acids are the body's detergents. So they work just like washing powder to make fat soluble. Okay. So that's what bile acids do. They're produced by the liver. They go out into the bowel, help absorb fat, and then get recirculated. They're the body's detergents. All right. Obviously, you eat meals, and then in between meals you don't eat, and so you don't need a steady state of bile acids in the beginning of the small bowel at the same level 24/7. You need it when you eat. All right, and that's what your gallbladder does. It acts as a pool for bile. It accumulates in between meals, and then when you eat a fatty meal, a hormone gets released by the stomach. It works on the gallbladder, and it goes squash like a toothpaste tube and squeezes the bile out into the bowel. Right, so that's why you've got a gallbladder. It's there to pool it. Now, in truth, you don't need that. You don't have any abnormality in absorption of food if you, in our modern world, if you don't have a gallbladder. So you can have your gallbladder removed without any effect on metabolism. It is functional in most people, but you don't really have a problem if you don't have it. Now, what on earth has that got to do with PBC? Well, PBC is a disease of wonky bile, is the best way to think about it. So the bile is abnormal in PBC. It's more gloopy, so it's thicker and more like toothpaste, less like water. And it also has a different pool of bile acids. So it has more toxic bile acids in it than it would have in a normal person. So the variation in the bile acids is greater. So you have more irritant bile acids, and it's generally gloopier. So the bile is abnormal in PBC, and so therefore the bile ducts are implicated in the disease, and the gallbladder is part of the bile ducts. Now, gloopy bile, for those of you, now I tell young people this, and they literally have no idea what I'm talking about, but Robert's almost as old as me, and he will remember growing crystals at school. I'm sure many people will do. He remembers, you see. So we all used to grow crystals where you would have what's called a supersaturated solution. So you'd really dissolve a load of a salt in a liquid, and then you would put a piece of thread in it, and a crystal would grow on it. And that's because it's got supersaturation. Once something focuses and gets deposited, that's literally what happens in bile with gallstones. So if the bile is very gloopy and concentrated, then there'll be a little focus, a cells have come off the wall or something like that, and that acts like a focus, and a crystal grows around it, and that's what gallstones are. And they grow in the gallbladder because the bile flow is intermittent. So the bile duct itself, bile flows through all the time, and so they get washed through. But in the gallbladder, they'll sit there for hours at a time, and you'll start to grow the crystals. So that's what gallstones are. They're crystals of bile. And so that's why you get them. And you get them more in PBC for the simple reason that the bile is gloopy, and so therefore it's easier to grow the crystals, and it's as simple as that. So you get gallstones a little bit more because you've got PBC. The gallstones don't cause PBC. PBC causes the gallstones, if you like. And so you will get gallstone pain a little bit more frequently in PBC in the ordinary population. And so therefore you'll have gallstone surgery a little bit more frequently than in the ordinary population. And so the very first lady I ever met with PBC was in 1988 when I was a surgical house officer, and I clerked her in. That's what the house officers do. Admitted her for her gallbladder surgery, and being the smarty pants that I still am, I diagnosed PBC rather than gallstone disease. And I got told I was a smarty pants, and they went into the theatre and to operate on her gallbladder, and in fact she had no gallstones because she had PBC. So that connection has always been there. Now the wild cards in all of this are that the connection between pain and PBC is a complicated one. So people will tend to think that pain over the right side of the abdomen is a feature of gallstones. All doctors are programmed to do that. And then they do liver blood tests and show that they're abnormal. And then, like that lady in 88, they then think, well, you're connected. The blood tests are abnormal. You've got pain. it's going to be gallstones, and then they will take the gallbladder out. And lo and behold, the pain doesn't improve because it was never gallstones. It was this sludgy bile you get with PBC. So in the past, people had too many gallbladder operations with PBC unnecessarily. So that's why the gallbladder is implicated in PBC. Urso was first invented as a treatment to dissolve gallstones. It actually dissolves gallstones very slowly. It's not that great a treatment for gallstones because if you're getting pain every day, you can't wait 2 years for it to work. But if you are taking it for another reason, then it's actually pretty good at dissolving gallstones. And we don't see anywhere near the gallstone problems we used to see. And I think that's the Urso effect. Okay, so I think that's the Urso effect. So it's another reason for taking Urso, but it's not the main one. Now, gallbladder polyps. What are gallbladder polyps? Well, they are little overgrowths of the cells in the bile duct. And you can get polyps in any tissue in the body. People will be very familiar with skin polyps, skin tags, very familiar with bowel polyps, which can give rise to bowel cancer. So you just get an overgrowth of some cells, and you get that in the gallbladder. They aren't particularly associated with gallstones or with PBC, but they get mistaken for gallstones, so people think they're the same thing. So why do gallbladder polyps matter? Well, 2 reasons. One is the pain of gallbladders is because the gallbladder squeezes and it's trying to squeeze the toothpaste out. But if the toothpaste is solid, it will squeeze and squeeze and it won't get it out. So that's why you get pain. And that same thing will happen with polyps as would happen with gallstones. So the gallbladder trying to squeeze a polyp out will give pain. So it's a reason to have your gallbladder out for pain, just as gallstones are. And then the other one is above a certain size, and I can't emphasize enough, it's above a certain size, they have a risk of turning nasty and turning into cancers. And it's a centimeter, 10 millimeters across is the magic figure. We go for a big margin of comfort, and I would tend to send anybody with a gallbladder polyp of bigger than 5 millimeters to see my colleagues who do gallbladder operations to start to think about whether it's the right time. So above 5 or growing below 5 and growing rapidly, because gallbladder cancer is not nice. You don't want that. Really easily prevented by removing the gallbladder. So that would be one. It's probably the commonest reason these days in our practice to do gallbladder surgery. So 5 millimeters and above, or if it's growing, or if they're causing pain. But they're not actually related to gallstones and not related to PBC, and obviously they won't dissolve with Urso. So we're seeing more gallstone. We're seeing more gallbladder polyp problems and less gallstone problems because the gallbladder problems aren't treated by Urso.
Right.
That's literally everything I know about gallbladders. Literally everything.
Okay. There you go. See, we bleed the well dry eventually. It's only taken us 4 years. Right. Okay. Thank you. We've had a number of questions coming in about AIH, PSC, PBC.
Yeah.
Now, there's a very specific question in the Click meeting room.
Yeah.
And I'm not entirely sure I know how to ask the question that would be beneficial to the room. So I'll let you read that whilst I'm kind of figuring that out. But what I'm going to ask you to do, again, just kind of a couple of minutes on each condition.
Yeah.
PBC, PSC, AIH. Now, some of this is feeding this section of Urso questions I'm going to ask you in a second.
Yeah.
Now, so for example, we've had somebody write in, say that my hep says I do not have AIH. When I'm only on Urso, my numbers go up. When I'm on Plaquenil or steroids, my liver numbers go down.
Mm-hmm.
So why could this possibly be? Am I on the right dose of Urso? So we'll talk about Urso dose shortly. Somebody's been diagnosed with PBC and AIH.
Yeah.
On steroids for 8 weeks. What are the statistics for success in that?
Yeah.
And then somebody's been put on prednisone for sepsis.
Yeah.
And hematologist says they are severely immune compromised.
Mm-hmm.
So can we talk a little just about those 3 conditions and just kind of set the record straight?
Yeah. Okay. So I'll talk about autoimmune hepatitis first, because in some ways it's the simplest. So autoimmune hepatitis is where the immune system recognizes the cells of the liver as being foreign and it attacks them. So it's actually the same process as would happen if you had viral hepatitis. So if you had hepatitis A infecting the cells of the liver, the immune system would see the hepatitis A, attack the liver cells and kill them off. And in AIH, it's happening because of a process of mimicry. So something's happened in the cells that's made it look foreign, all right? So it's just the same as, say, thyroid disease or type 1 diabetes. So type 1 diabetes, the immune system recognizes the beta cells of the pancreatic islet that produce insulin as being foreign, mounts an immune response to them and gets rid of them. So it's a really simple, classical autoimmune condition. Now, conditions like that will continue until one of two things happens. One is the body regains control, which sometimes happens, but more commonly you run out of liver cells for, the fire burns out when there are no more trees to burn. So you run out of liver cells, and so that's a very significant situation. Sometimes the immune system can re-establish control, or the doctors give you something that switches the immune system off, and that's where prednisolone and the various other immunosuppressive drugs come from. So autoimmune hepatitis, there is no other treatment in the first instance than steroids, although there are some alternatives for steroids later on to keep it under control. But you are using it to switch off the immune system and to keep it under control to stop the liver being damaged. So that's a disease of the liver cells. So PBC is the next simplest, because that's a disease of the bile duct cells and not the liver cells. So there's still cells in the liver, but it's the ones lining the bile ducts, not the actual liver cells. And because it's not the liver cells that are attacked, you don't get liver failure with it. What you do is get bile duct failure. So you lose the ability to flow bile normally, and that has all the effects that we've talked about. So the bile builds up and irritates in the liver, causing some secondary damage, and it obviously has the effects on nutrition that we've talked about. Okay, so it's a disease of not liver injury, it's of bile duct injury. And interestingly, the treatments we use are not steroids and things. The reason being, you don't need them, because if you simply take away the consequences of the bile duct failure by altering the bile acid pool, that does the trick for most people, although we many years ago looked at steroids for the treatment of PBC. And the answer is they actually work, but they don't work to an extent that makes it worth the side effects that people get with them. So it's not they don't work, it's that you don't need to use them. That's an important distinction. So PSC is a really complicated condition for a variety of reasons. And it too is a disease of bile duct failure, but it is a more complicated version of bile duct failure because it can affect different bits of the bile duct in different ways. So PBC is a disease of the small bile ducts within the liver. PSC is the disease of any of the bile ducts all the way down from the small bile ducts in the liver all the way around to the big bile duct that joins the bowel, and in fact the gallbladder. So there's something additional I didn't know about gallbladders. It's when I said that's everything I know, I found something else. So it's a disease of anywhere in the bile ducts, and that gives you very different appearances in different people. It's a disease of scarring, not a chemical effect, so that makes it very difficult to treat. So it's all about scar formation. And then the big difference, really big difference, is it's associated with cancer. So it's associated with bile duct cancer, and it's also associated with colon cancer, neither of which you see in PBC or autoimmune hepatitis. And so therefore, and it has no therapy at the moment, unlike PBC, where we have good therapies and new therapies, and ditto with autoimmune hepatitis. So it is like a complex version of PBC with a few stings in the tail. Now, just if that wasn't complicated enough, you can also get situations where you have a bit of two of those conditions. And the connection is always autoimmune hepatitis. So you can have PBC with some features of autoimmune hepatitis, and autoimmune hepatitis with some features of PBC. You can have a 100% one, 100% the other, 90-10, 50-50, 10-90, 100, 0. And you can also get an association between autoimmune hepatitis and PSC. although you never get an association between PBC and PSC. So the connection is always autoimmune hepatitis. Now, if you have both PBC and autoimmune hepatitis, then you need to treat both of them as you would treat each of them individually. So you treat the PBC as you treat the PBC, and you treat the autoimmune hepatitis as you would treat the autoimmune hepatitis. And that's really important. If there genuinely are both there, you genuinely need to treat both. And if it's autoimmune hepatitis and PSC, you need to certainly treat the autoimmune hepatitis. There is no treatment for PSC, but we know that the autoimmune hepatitis can burn out into a PSC-like appearance, so that becomes very important. Okay, so you've got 3 conditions and 2 overlap syndromes between them. And if that wasn't complicated enough, we now know that PBC itself can look a lot like autoimmune hepatitis. So in the past, it was an article of faith amongst the pathologists that a particular process you see in the liver, so some actual inflammation around the liver cells, we call interface hepatitis, is always a feature of autoimmune hepatitis. In fact, it isn't always a feature of autoimmune hepatitis. It can also be a feature of PBC in people who don't respond to urso. So it can also be a feature of more aggressive PBC. What that means is there are a lot of legacy people who were diagnosed with overlap a long time ago, who, if we were to look at them again, don't have overlap. They have the more aggressive form of PBC. And of course, the treatments are very different. We know that steroids are not a particularly good treatment for the more aggressive form of PBC, whereas drugs like obeticholic acid and bezafibrate, some of the newer drugs, are very good treatments for that. So misdiagnosing overlap leaves people on steroids and azathioprine and things when they don't need them and won't benefit from them, and means that people don't get the right treatment. So we are progressively looking at everybody who's ever had a diagnosis of overlap to look at it critically. Now, at the end of the day, I can predict with a reasonable accuracy whether somebody has bad PBC or overlap. Okay, and that's based on the nuances of the blood test values and some of the nuances of the biopsy. But I get it wrong. And I remember not so long ago in the clinic, one of the fellows had started somebody on steroids with what looked like urso non-responsive PBC, and I was going, why have they started them on steroids? All of that, need to educate them properly. And then I looked at the test, and they'd all completely normalized on steroids. So I would never in a million years have thought that was overlap, but it was. So at the end of the day, the only true way to know if it's overlap is to treat with steroids, okay, which adds complexity. Now, if it is overlap, then the aspect related to autoimmune hepatitis, which is the ALT blood test, which is different to the ALP, which is the PBC one, will improve rapidly. And there is another test called the IgG, which is always elevated in autoimmune hepatitis, and that will improve rapidly. If those don't improve rapidly with a month of steroids, then however suggestive it is, it aims at autoimmune hepatitis. And if those treatments aren't working, which they're not, you should stop them. So we only ever use what we call a trial of steroids. It's for a fixed period of time for 4 weeks. And then we make an objective decision about whether there is sufficient evidence to do it. So we tend not to talk about overlap because it has baggage to the past. We tend to talk about steroid and non-steroid responsive components to the disease. So the really important question is there something in this individual that is likely to be steroid responsive, in which case you do a trial of steroids, and if not, you go down second-line therapy for PBC. Gideon, who many of you will know, always says that it's about 10-to-1 high-risk PBC versus overlap, and I think he's probably about right. So anybody who's out there who's on steroids and azathioprine has done for years, and the tests still aren't normal, go and talk to your doctor and say, should I be on obeticholic acid, basically? And I can tell you of, lots of people who come to see me. A very nice lady who was wrecked by steroid side effects and long-term steroid side effects, and never ever got control of a disease, and now she's got perfect disease on urso and bezafibrate.
Perfect. Okay.
So it's worth looking at it critically. PSC is more complicated. In the question specifically, there is something that is worth talking about, which is diagnosing. This is somebody who had sepsis. So sepsis is a blood infection, bacteria getting into the blood. It usually is a result of a water infection or a gallbladder infection or something like that. And somebody who had abnormal liver tests after that, and has been investigated and has been found to not have any autoantibodies. And the question is, do they have an antibody negative PBC or an antibody negative PSC? Okay. And the reason I wanted to mention is because this is a very important trap people fall into. So this is a man. Okay. So men that almost never get antibody negative PBC. So PBC is 90% women, and of the men who we do see, 98% have antibodies. So you can, as the Americans say, do the math on that. The chances, the number of PBC patients who are AMA negative or antibody negative men is almost infinitesimally small. So I would look at something else. So PSC is commoner in men than in women. So that is a plausible thing to think about. But the MRCP was negative. Okay. The MRCP was negative. Now that is the definitive test for PSC. So the antibodies are negative and the MRCP is negative. So that's looking like not PSC to me. And the biopsy showed drug-induced changes. That's starting to sound like something different. And the trap I wanted to discuss is that sepsis itself causes bile duct injury. Probably the commonest thing that people phone me up about when I'm on call for the liver unit, the general liver practice we do, is sick people with abnormal liver blood tests. And it's always a PBC-like pattern. And it is part of the effects of sepsis. So all of those effects of sepsis, they affect your kidneys and they affect your heart, but they also affect your bile duct. So you get a mild version of PBC or PSC with bile duct injury with sepsis, but it will improve after time. We treat everybody with urso in that situation because it's a non-specific healer of the bile ducts, but you don't need anything else. At some point, somebody needs to check that off urso your blood tests return to normal. And if they don't return to normal, you need to have the MRCP repeated in a year or so. And I do appreciate we've crossed the line into specific medical guidance, but we see this time and time again. Post-sepsis liver function tests being overinterpreted. But just if all the tests are negative, that usually suggests that it's nothing to do with PBC or PSC or autoimmune hepatitis.
Perfect. Thank you so much. Right. We have now, so that was the section on the three main autoimmune cholestatic liver diseases. So thank you for that. If I may, I'm now going to ask a series of questions about URSO.
Yeah.
And probably what we'll do is we'll edit this into a kind of little 10, 15 minute section, or 20 minutes if we do quick fire. But have a standalone section on URSO, because I think this is really important and there's some really vital questions that have come in. So first question, if I may. I'm scared of taking URSO because I've heard it gives some people thinning hair and weight gain. Will this happen? And if it does, is it likely to settle down or go back to normal?
Okay, so hair loss and weight gain. So a lot of people talk about hair loss. It's difficult to know the significance of it. There are reasons why people kind of lose hair, if you like. With PBC, so people are unwell for any reason can do that. Thyroid disease, they can do that. Annodomini can do that. There is a sort of recognition that you get it with PBC patients starting URSO, and there is a danger then that people put some hair loss down to the URSO. So what do I think? Well, what do I know about hair loss? But hair loss, I think you do get a little bit of hair loss with URSO, okay? I think you do get a little bit. But it's usually not dramatic. But, it can happen. Now, weight gain, and I'll talk about, the context in a second. Now, weight gain is, again, reported. That's been published by Keith Lindor, who's a very good observer of all of this. So he reported around about a 3-pound increase in weight on average, starting with URSO. Now, there is a very good explanation. I have no explanation why URSO would cause hair loss. There is a very good explanation why URSO would cause weight gain, because remember, you're underproducing bile acids. And you need bile acids to absorb fat from your diet. And so if you give people bile acids, which is what URSO is, you're helping them to absorb fat. And so basically, PBC will help you lose weight a little bit because it runs you a little bit on the under absorption of food side. So weight gain will happen, and we do warn people about it, and in order to mitigate the effects. Now, the weight gain, I think, fundamentally with URSO, it is the extent to which the benefits versus any of these side effects, would fall. And I think, if somebody was, say, 90 with very minimally abnormal liver function tests, who had big problems, all of these, well, you can argue that the benefit is relatively low. They don't need treatment quite so much. If you are 40 with a very high alkaline phosphatase, I think it's a false economy to not take those treatments, because you're worried about, those other potential side effects. And I think the worry about these is more of an issue than the reality. So what I would do is I would look at the whole picture, and I would look at, how badly I felt I needed the treatment, if you like, based on, the risk factors and things like that. But I would always err on the side of taking it. But I think I wouldn't over worry about it. I would take URSO and see what happens. Now, for people who can't tolerate URSO, obeticholic acid is also licensed, and it is licensed for people who are intolerant of URSO. So we can use it in people who are unable to take URSO, and I've certainly used it in someone who did get quite distressing hair loss. And I think that's a reasonable thing to do. It brings its own problems around it, so you need to be aware of that. It never causes hair loss. It doesn't cause weight gain because of the mode of action. So there is always an alternative plan. I wouldn't tend to use obeticholic acid because of fear of weight gain. I think you're putting too much on a relatively minor issue and perhaps neglecting some of the other things. So I wouldn't be over worried about URSO. The vast majority of people have no meaningful problems with it, but there is always a way. But I certainly wouldn't go to obeticholic acid because of worry about hair loss. I think it would be something you'd want to see. Would you agree with that, Robert?
Absolutely. I think it's something, particularly, if you're of a certain age, and I mean this in the most polite sense, that you're still at a point where your appearance is important. And when you're dealing with the new concept of living with PBC and look at therapies, to have this other thing hanging over you, is it a potential? Is it real? How bad is it? It does have an impact in terms of what your thinking is and how you respond to it. So I think it's important to ask these questions, but the reality tends to be more about a slight thinning than it is about a hair loss per se. So yeah, but absolutely, that's helpful. Thank you. Next question about URSO, if I may. Is it inevitable that I will get liver damage even if I respond to URSO?
Sorry, what was that? Sorry, I missed the beginning of that.
Is it inevitable that I will get liver damage even if I respond to URSO?
No. I think it's about the degree of response. So
Yep.
I think what's at the heart of that question is, what do we mean by response? And I think that's really important. Now, I think that life is a learning experience, and we all learn. And some people, it takes longer to learn than others. when we were introducing therapies to PBC, everyone got strung out on the concept of response and non-response to URSO. Okay, so I'll be honest with people. I think this is how it arose. I think people, in a way, wanted to protect, became very wedded to URSO. Okay, now most people would think if you've got abnormal tests, then returning to normal is the response to treatment, isn't it? I mean, when you've got diabetes, the goal of treatment is to return your sugars to the levels that people who don't have diabetes don't have. And I think in the old days, we used to look to reduce glucose, but didn't try and get it back to the normal range, and people got a lot of complications from it. So why did we kind of play down the lack of impact of URSO? It normalizes very few people. I think that was because people were wedded to it, and there were very strong advocates for it. And I think for those reasons, people were very wedded to it. But it's colored our thinking ever since, because if we still think URSO is really effective, but it doesn't return tests to normal, then we slipped into that trap with some of the other therapies that have come along. So also, we kind of moving to saying, well, if those treatments, if you don't return to normal, that's still fine, because that's fine with URSO. I think we made a mistake, and we should have had a lot of simpler thinking, and it's become a rod for our own backs. And I think there's now pretty clear-cut evidence that people who have responded to URSO fall into two groups. There are those people with normal tests who have no risk at all, and there are those people who have slightly abnormal tests, but they are within the response range, who have some residual risk of liver injury. Now, that risk is clearly a lot less than people who are responders. Of course it is. And that's clear cut. However, it's still there. And I think increasingly we're going to focus on removing that risk in people who that risk might be significant to them. Now, what risk is significant to an individual, again, goes back to the individual. My metaphorical 90-year-old, well, a 30-year risk of liver injury isn't, maybe something you need to be worried about, but if you're 40, it is. And so increasingly, we are going to be looking to have normal tests for people who need a lot of years out of their liver. So in answer to the question, if you respond to URSO in terms of having a normal set of liver function tests, we are pretty confident that if your liver is not scarred, your FibroScan is normal, and you respond with normal liver function tests, you will guarantee live a normal life with PBC. If, however, you have slightly abnormal liver function tests that are still in the response range, there is a danger that you will have a sort of grumbling level of injury and will get problems over time. But they will never be as significant as people who haven't responded.
Yep. Okay. Thank you. If I haven't responded to URSO, do I just take more URSO?
Yeah. Okay. So up to a point. So URSO relies on getting into your bile pool in replacing the toxic bile acids. Okay. So it relies on that getting into the system. Okay. And it takes time to do that, and it has several rounds of enrichment. So if you take an URSO tablet, it goes through your gut, gets taken up, goes back to the liver, goes round again. But on the second time around, it meets the next tablet, and so you have rounds of enrichment. Now, different people will enrich to different degrees. And different doses. So no two people are the same. And obviously, the longer you take the URSO and the more you take, the more you will enrich it. But there is a law of diminishing returns, and it is pretty much impossible to get beyond about 70% URSO, even if you take vast doses for a long period of time. So probably 50% is a reasonable goal. So for most people, 15 milligrams per kilogram will give you that within about 3 months. So that's why you need that length of time, 13 to 15 milligrams per kilogram. Can you force it higher by taking a higher dose? Well, possibly, but there's a caveat. So urso is very safe indeed, but there was a trial in PSC where very high doses actually gave increased risk of death rather than reduced. And it's thought that if you take a vast dose of urso, it actually just clogs the whole system up and means it actually makes bile flow less. That was 25 milligrams per kilogram, and that's the reason we will go. I think there is no evidence that going beyond 15 makes a meaningful difference. We have done it on occasions in people. I think going from 13 to 15 within that band can have an effect. Certainly going from 10 to 13 will do it. But going above 15, it's the law of diminishing returns. And don't go above 20 ever because it's risk.
Okay. And when you're looking at urso response, what would we say is a good enough response? And where are the thresholds in terms of looking at additional therapies?
Yeah. Just give us 2 seconds. There's something urgent I need to respond to.
Okay.
Whoops.
So the question that we're going to ask Dave is about urso response in terms of what do we think the measurements are in terms of normal, above normal, but okay, and above normal and still needs additional therapies. So that's going to be the question that Dave will address in a second. So this is living proof that as well as doing this kind of work, that what we have are living, breathing, real doctors that are doing real work on top of giving us. So thank you. So in terms of urso response, normal, what does normal mean? And when should we be looking at adding on second therapies?
Okay. So what's normal in any test? So normal in any test is done by taking 1,000 healthy volunteers and measuring that test in those 1,000 people. And you will get a distribution like that. So there will be a certain value that is most frequently seen, and then you'll get a variation in values. Think of height in the population, okay? So you have some 4'10" people and 6'10" people. There aren't that many of them, but they're still normal, but most people are 5'11", okay? So it's a little bit like that. We call that a normal distribution. There is a statistical way of looking at that where we look at what are called standard deviations. So that is a measure of the distribution, okay? And standard deviations reflect the sort of variation that you see in it. And 2 standard deviations is conventionally regarded as, a standard deviation, then another one is regarded as the standard for being an outlier to what's normal. Now that's a statistical convention. It's not handed down on tablets from on high. It's a statistical convention. What does that mean in practice? Well, for a test like alkaline phosphatase, about 2.5% of the population will be normal and have a value above the mean plus 2 standard deviations, and about 2.5% will have it below the mean minus 2 standard deviations, right? So that's 5% of totally normal people will be abnormal. And that's really important to remember, because if you have 20 tests done by your doctor, statistically, one of those by chance will be abnormal even though you're normal. Never forget that. And that's why you look at panels of tests. Gamma GT is a classic example. So gamma GT is another test a little bit like alkaline phosphatase. It's just not quite as useful. Why do we use it then? Well, if you've got a slightly elevated alkaline phosphatase, you could be one of those 2.5% of people who are normal but have a slightly high value for statistical reasons. But if you also have a high alkaline phosphatase, then it suggests that they are linked mechanistically, because statistically they wouldn't be, right, at all. So it's plus or minus 2 standard deviations. So that your normal alkaline phosphatase is the mean in a healthy population plus 2 standard deviations, and that gives you a value of 130, okay? Now, if you have an alkaline phosphatase of 140, what does that mean? Well, it could mean one of 2 things. One is it could mean you're completely normal, and that's just normal for you. You're 7 foot, but you're still healthy and normal. It's not an illness, it's just you're different. Your parents were tall. because unless you've ever had your ALP-FOS measured before, you don't know what's normal for you. So that's the first thing to say, is that any individual value on its own is difficult to interpret. Yeah, fine, if it's 1,000, it's abnormal. But if it's marginally elevated, it's difficult to know if that's normal for you. Well, the other possibility is it's very slightly elevated. In terms of what we regarded as normal, as a response, we regarded 1.67 times the upper limit of normal as the optimum thing. You were aiming with any treatment to get below that level. You were aiming to get below that level. Okay. Now, why was 1.67 times the upper limit of normal chosen? Well, again, it was based on a bit of statistical, magic sleight of hand. And realistically, it's a continuum. The higher alkaline phosphatase, the more the risk is. And it was just regarded as a reasonable cutoff. I mean, it's not scientific at all. It's rather plucked out from the air. But it's ended up with this kind of godlike status. This kind of godlike status as being the be-all and end-all. And then the French introduced 1.5 for no particular additional reasons. And this is the problem, is that these really were, sure, people with an ALP-FOS above 1.67 times upper limit normal had a bigger risk than people below the normal range, but, it's all shades of grey. So the only really robust statistical model is the mean plus 2 standard deviations, and therefore you should really go for normal if you want to minimize risk. So it goes back to what we were saying before. Now, do you need additional therapy if you are not in the normal range or not in the response range? For the normal, if you're not within the normal range, as I said, it depends on all manner of different factors. And I think that's an individual decision. And we would talk to people about it in terms of their own personal settings, right? I've certainly had a conversation. I've had conversations with people who've got AMA and normal liver function tests, and you talk to them about the risk of that turning into PBC being relatively low, et cetera, et cetera, et cetera. And then they tell you that their mum and their grandmother both had liver transplants for PBC, right? I can tell you that this is low risk until you're blue in the face. Your family experience is this is not low risk. And that person went on to URSO, as I would have done in that same situation. So it's where guidelines are very difficult. Guidelines are the kind of scripts that all doctors work to. But, as anyone knows, a scripted comedy is funny, but improvised comedy is really funny. And so you sometimes need to not just stick to the script. You need to adapt it to the person you're seeing in front of you, like a comedian would adapt it to their audience. So there is no hard and fast rule. The rule of thumb at the moment is everyone needs an ALP-FOS below 1.67 times the upper limit of normal. That does leave some people at an increased risk that's meaningful because of their age, personal risk factors, etc. I think the new benchmark will be normal. New benchmark will be normal. And I think if people reach that benchmark, then they can be very confident. But it should not be seen as a mandatory target, if you like.
Perfect. Thank you. Does URSO prevent symptoms from happening?
So the short answer is nobody knows. Nobody knows because nobody's ever watched it, because you would have to do that in a placebo-controlled trial, because obviously people develop symptoms. And if you have a population taking URSO, they develop symptoms at a certain rate. Is that different or to how PBC patients would normally develop symptoms? So you just don't know. And of course, the URSO trials were in the days when people failed to recognize, shall we say, that symptoms were important. So that's part of the journey we've all been on, that some of my predecessors and still colleagues in PBC don't really understand or appreciate the importance of symptoms. Mm-hmm. I was in a debate with somebody yesterday who was saying, but if the liver blood tests are normal with the treatment, that's all you need, isn't it? No. So unfortunately, all those studies were done in the days before people looked at symptoms. So now we couldn't possibly do a placebo-controlled trial. So we can't possibly do those studies, right? So now, what do I personally think? I personally think that if you control PBC well enough, early enough, and before symptoms have developed, you will stop symptoms from developing. I'm convinced of that, actually, because of our work around really aggressive treatment in early disease. So I would struggle to think of anybody who developed significant fatigue or itch who didn't have it already to some degree before we started treatment, provided they were in really early disease. Now, I can't quote you any data, I can't show you any graphs, I can't prove that, but I've probably, as a doctor, I've probably spoken to more PBC patients than anybody else in the world, because that's what I've done for all these years, and we look after 1,000+ patients. And based on that, I'm pretty convinced. And that's why I'm convinced that earlier, better treatment is the secret in PBC. That we wait to fail, that might have a knock-on effect in terms of progression of the disease. But I'm convinced it opens up the door for people developing symptoms. So I think, and as I always say, early treatment of meningitis and antibiotics is good at saving people's lives, but it also stops you getting a bad headache as well. And I think earlier, better treatment is the future. So I think step one is targeting normalization, but step two is going to be earlier, better treatment to stop these issues arising in the first place.
Perfect, thank you. And my last URSO question, does URSO cause frequent bowel motions?
Yes. So its issue is bowel disturbance. Okay, bile acids cause people to get diarrhea. There is in fact a condition called bile acid diarrhea. Okay, so actually there are people who have excess production of bile acids, gives them horrendous diarrhea. And it's horrible. If you have people who've had the end of their terminal ileum removed, they've had terminal ileum removed, they don't reabsorb their bile acids. The bile acids all go into the colon. They get terrible diarrhea. Okay, so bile acids do that. So URSO is a bile acid. It causes loosening of the stool. You also get gastric disturbance. You get gastric irritation. So you get, irritated stomach. We all know what bile vomiting tastes like. You get an element of that. Now, it is the main reason why people are intolerant of URSO. Okay, so about 5% of people given OCA, obeticholic acid worldwide, have been given it because they are intolerant of URSO. So that's the lesser reason for using it. And almost all of those, one or two are hair loss, okay, but the vast majority of those are just the GI disturbance, top or bottom. They just can't tolerate it. And what we do in those situations is we try split doses and we try lower doses and build them up. We try taking it with food, for food, after food, all manner of different ways of doing it, but they just can't tolerate it. In those situations, we use obeticholic acid, and actually we don't encounter any of those problems with obeticholic acid. It's probably the bile acid load. Obeticholic acid is also a bile acid, okay, but we use it at a vastly lower dose. So we're using 1,000 milligrams of URSO. So that's 1,000 milligrams of bile acid a day. Obeticholic acid, we're using 5 milligrams. So it's 1/200th the dose. So you get much less in the way of problems. So yes, I mean, if it's upper GI discomfort, that's quite difficult. You can try antacids and things like that, but it's a chemical irritation. For loose stools, it's actually fluid being drawn into the colon. Actually, it's not irritation, it's fluid. So actually, it's fine to take loperamide or something like that. So it's easier to control than the upper GI problems, which are just a chemical irritation. It's quite difficult to get around it.
Yeah. We've often heard from patients who start URSO, and then their movements are more loose, and then that just settles down.
Yes. And that's because your body adapts. Okay, so your body adapts the uptake of bile acids in the terminal ileum, and so basically the lower GI is this oncotic effect. It's the fluid effect. But if you take the bile acid back up, more effectively in the small bowel, then you won't have that issue.
Yeah. Okay. Perfect. Thank you. Okay. That's the ursal section. So we're going to do a very, and this is quick fire. But
Yes.
We're going to do PBC and.
Yes.
So here we go. PBC and shingles vaccines.
Fine.
PBC and Botox and fillers.
I've never been asked that question. As you can see, I'm not somebody who uses much Botox. I can't see any issue with that because by definition, they're topical treatments. PBC in general does not give problems with other drugs because it doesn't affect. So liver disease and drugs can be a problem, but in general, PBC, because it doesn't affect liver function, does not tend to give you those problems. So I am not aware of any issues with that, and I can't think there would be, but that is my best guess rather than knowledge on it.
Okay, perfect. Thank you. PBC and Maloth Protect tablets, which is an anti-malaria. One of the side effects is blockage to the bile duct, so there's obviously a concern there.
How do you spell it? I will quickly look.
Malof Protect.
Okay, yeah. Okay, so Malarone, right. Just talk amongst yourselves. I'll look up on the BNF.
All right. Okay. Perfect. Thank you.
So I'm just goes 2 seconds. I'm looking at the standard resource that we look. This is a really important lesson for doctors. Don't assume you know these things. If you haven't come across it, it's important like this. Now, instantly, I'm more worried about this because these are systemic and are known to have systemic side effects, right? So it's very different to Botox for that reason. It sort of has the potential to be issues, right? Okay.
So you get wisdom, knowledge, and music.
Well, okay.
And just for background, this is somebody who's F3-4 who's on Urso and Biza.
Yeah. It's okay.
All right, perfect. Thank you.
So I've not done a detailed search on it, as you'd appreciate. If I was asked that question in the clinic, I would say it was fine. That we have a standard resource that we look at for toxicity interactions, etc. And there's nothing flagging on there that I would be concerned about. What I would say with it is that these are anti-malarials are something that have a reputation of being a bit tricksy. By that, they will create issues. They're a class of drugs you need to be careful with. So the fact that somebody hasn't reported something does not indicate it doesn't happen. It means that somebody hasn't reported it. So I would always apply the cautionary principle. So I think it's fine to take it, but I would have a very low threshold for stopping it if you had any reason to think that there was any change with it with regard to either symptoms or blood tests. So there is no caution, but there's a flag that goes up with those that wouldn't be there with, say, Botox.
Okay, perfect. Thank you very much. PBC and cannabis edibles.
Now, medicinal cannabis. I'm going to tell you something I've never said before. George Mells and I, you know George very well. So George and I did a piece of work looking at the genes of PBC, which many people on this call will have participated in the study of, and looked at what that told us about what drugs potentially might benefit PBC. So we tend to look at the drugs we first think of, okay? So we tend to look at, you know, the obvious drugs we think of. But sometimes there are some drugs that we haven't thought of that might work, and we haven't thought of them because we haven't thought of them, and to look at potential interactions with the pathways that are important in PBC. And one of the drugs that comes up with that is medicinal cannabis, interestingly. Okay. So medicinal cannabis, certainly we've never encountered any problems with it. And, you know, I will be the first to say we've had a number of people who've used cannabis in its less medicinal form for control of symptoms and haven't had any problems with it. Some of them reported some benefit from it. You read into that what you want, but we haven't had any problems with it. But theoretically, medicinal cannabis would actually be beneficial for PBC. And I think if we ever got around to doing what we call an adaptive trial, where we add in different drugs into a platform, I think it would be something that's worth looking at. But there is no evidence that it's harmful, and there is at least theoretical evidence it's beneficial.
Okay, perfect. PBC in pregnancy.
PBC in pregnancy.
Not necessarily a quick fire question, but I'm aware of time.
PBC in pregnancy is absolutely fine. There is nonsense on the internet, absolute nonsense on the internet from people who should know better, that scares people. But we've had not a huge number of pregnancies in our patients to do with age and demographics, I guess, more than anything else. But we've had a number, and we've never encountered any pregnancy problems. And I've never encountered people feeling that they've had a problem getting pregnant over and above, you know, the normal vicissitudes of life. Now, that's not true of autoimmune hepatitis. Actually, autoimmune hepatitis is problematic for getting pregnant, but I don't think with PBC. So we get a number of babies coming through the clinic, and everyone really likes that, and we don't see any particular problem. Now, things to watch out for. Anybody with cirrhosis of any type, because of the pressure changes in the abdomen during pregnancy, you can get variceal bleeding in the third trimester, the final third of pregnancy. This is only people with cirrhosis, so very uncommon in PBC, very uncommon. But anybody who's got cirrhosis needs to have an endoscopy at the end of the second trimester in order to assess their risk of having bleed. It's just simply the baby pressing on blood vessels. So that's the first caveat. The second caveat is that some autoimmune diseases flare up after pregnancy because of the effects of the pregnancy on the immune system. Autoimmune hepatitis notoriously does. It flares up 6 weeks after the baby's born every single time. I don't think PBC does. I've never convincingly seen it, but we would always tend to look at people pretty early on after the baby's born, just to make sure that hasn't happened. Okay. And then the third is, this is small print, but really, 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 really important, is that drugs like urso and azathioprine and bezafibrate and obeticholic acid basically are safe in pregnancy. So the information will say avoid in pregnancy, but that's because all drugs are avoid in pregnancy, because nobody ever does trials in pregnancy for obvious reasons to show the drugs are safe. So that's a lack of evidence to prove that they're safe. So therefore, that's the argument not to use them. There are some drugs that are complete no-nos in pregnancy because they are teratogenic. And by teratogenic, I mean do the things that thalidomide did. People are familiar with that. And one of those is MMF. Okay, so MMF is a complete and utter no-no for anybody who thinks that they might possibly get pregnant. Okay, it causes actual deformities in the baby. Now, that won't affect 99% of the people on this call, but there will be some people post-transplant, and there will be maybe 1 or 2 people with overlap, see previous discussion. But MMF is a total no-no with pregnancy, and that is not just doctors going, oh, don't take any pregnancy. It's a total no-no.
Okay, perfect. Thank you. And the last one, PBC and Alzheimer's. Is there any known associated risk?
No, not at all. Not at all. However, there is an association with concern about memory because of the cognitive symptoms of PBC. And I get asked this question all the time. And actually, I raise this issue even in people who haven't asked it, because I suspect that people are thinking about it. And I had a lady just last week in the symptoms clinic who was worried about her symptoms. And, I asked her, she said about memory and concentration and things like that. And I said, look, are you worried about this? And she said, yeah. And I said, you're worried about dementia, aren't you? And she said, oh, yeah, I then wanted to say. I said, right, I can put your mind at rest. PBC has no greater incidence of dementia than in the ordinary population. However, you will have these relatively mild memory and concentration problems sometimes that are an irritation and will get in the way of life. They do not turn into dementia. It's not the beginnings of dementia, and you don't need to worry about. They are a PBC problem. So that's what I say to people. So there is no statistical association between diagnosed Alzheimer's and PBC, but there can be a bit of a misdiagnosis around memory and concentration.
Perfect. All right. Thank you. And the very, very last question is PBC.
Is that different to the last question?
It is slightly different to the last question. PBC and controlling body temperature.
Yeah, it's an interesting one. That people talk about it all the time. There are two things that I think are associated with it. One is thyroid disease. Thyroid hormone is the master regulator of body temperature. Third of PBC patients will develop thyroid problems. Okay. Third of patients over time. So it's a very live thing. So we would always automatically recheck thyroid function. The other one is autonomic dysfunction. So we've talked many times about dizziness when people stand up, about blood pressure regulation being abnormal in PBC, and it's linked to fatigue. But it also links to other aspects of the autonomic nervous system and the body's response to it, one of which is flushing and temperature control. Not because your core temperature changes, but because the blood flow to and from the surface changes. So that's the commonest reason why people with PBC feel like they've got temperature changes. It's because they've got this cutaneous effect. And so we would manage it as we manage the autonomic dysfunction of PBC through fluid regulation. The way you work out the difference is that thyroid disease is associated with a genuine rise in temperature when you do the old thermometer under the tongue routine. But the autonomic isn't. It's a perception of temperature rather than actual temperature. So I always tell people the first thing to do, if you think you're getting temperature regulation problems, is actually get a thermometer or one of the ones you stick in the ear or whatever, and just do a regular series of temperatures. And that's the first test you do, because you diverge in the possibilities pretty quickly. And obviously, don't forget the menopause as a potential cause of this. It's not a feature of PBC. It's a feature of the demographics of people who get PBC. Okay.
Perfect. All right.
And I will confess, as I confess to the great God Davina, we, meaning male dinosaurs like me, did not take the impact of menopause symptoms in PBC as seriously as we should have done. And I mea culpa for that, but we now actively talk about it. We have leaflets around it, and we are very proactive about it. And we are all human, and we are all have our failings, and I don't think we took that as seriously as we should have done. There you go.
Brilliant. Thank you for ending on that note. That's a really important note.
And we are using a lot of HRT now to reduce the overall symptom burden that people are living with, and it's really effective. And there are no issues taking HRT. There's some nuances about taking patches and things, but I think we probably have missed a trick, but we don't anymore. And that's all you can say, really.
Perfect. Thank you so much. Okay, so lots of questions not answered. We've done the best we could in the time allocated. We've given you as much detail as we can. If you do have a question that is unanswered, please do write to us directly, because sometimes it will be helpful just to talk to one of our trained staff and to support you in your journey. Professor Dave Jones, OBE, thank you so much for today.
And just to say about that phoning the team at the foundation, we send a lot of people to talk to the team at the foundation. Okay. And it's all about perspectives on all of this. Okay. And we all come at it from a different direction. I do it from a direction. My nurse colleagues do it from a different direction. The foundation team from another direction. So it's an incredibly valuable resource, and we do it again because there's a different type of information given in a different way, and it's all complementary. And I think the thing you can be absolutely assured about with the foundation is that you won't get disjointed guidance. Everything's joined up. That's what people like me and George and my colleagues are here to do, is to make sure that all the information is as good as you'll get anywhere in the world, and you're not going to get any duff information. And as you all know with the internet, there's a lot of duff information out there, but not on the PBC Foundation website. Full stop.
On that note, we'll close it off there. Thank you so much.
Great discussion. I really enjoyed that, everyone.
Thanks, Dave. Thanks, everyone. Appreciate your questions. We'll see you soon.